So in the handout, the next thing in objective 3 is something we've actually already done. So modeling how pain is blocked when an opiate like heroin or morphine is introduced in the brain. So we reviewed this when we were talking about neural signaling. And what I'll do is on Canvas you'll see that this opiates and pain video is reposted. And things to think about is that you have that pain stimulus that's going to lead to action potentials and release of glutamate, and then that's going to lead to the perception of pain. But you also have opiate receptors, sorry for the misspelling, and if we activate those opioid receptors, we're going to have inhibition in two places, that presynaptic inhibition and that postsynaptic inhibition. And that comes into play because what we see here, right, you have that presynaptic opiates and you have presynaptic opiate receptors and postsynaptic opiate receptors as well, right? And those are both going to be inhibitory at the presynaptic to prevent the release of neurotransmitters, and inhibitory at the postsynaptic to prevent the signal from moving on in that postsynaptic cell. And in addition to those opiates that we have already looked at, you can see there's more signaling that's happened here. And so if we have SSRIs, which are going to increase serotonin, right? That serotonin in this blue, you can see they're binding to those inhibitory serotonin receptors, again, presynaptically and postsynaptically. So you can use SSRIs to manage pain. You can also use norepinephrine reuptake inhibitors to increase the presence of norepinephrine. So you see here this gray, you have norepinephrine, which represented here as acting presynaptically and postsynaptically as well to inhibit pain signal. So one of the things you also have, so those tricyclic antidepressants and selective norepinephrine reuptake inhibitors, or serotonin and norepinephrine reuptake inhibitors. Sorry, that's what the S means here. So those are going to act both on serotonin and norepinephrine. And when you do that, when you increase serotonin and you increase norepinephrine, those are both going to inhibit that second order neuron in that pain pathway, and so you're going to decrease pain. So often these are used in treatment for depression, but can also be useful in pain management as well. And when we look into a different classification of drugs, these non-steroidal anti-inflammatory drugs and their role in pain management, I'm going to first start down with this picture here, because this is similar to what we saw in the one above, and I want to orient you. So this is that purple neuron. So here's the cell body. You have the DRG, or the dorsal root ganglion, where that cell body is, and then that purple neuron is coming into the spinal cord here. And then the other image, that this would be where the glutamate is released. That information is, or glutamate and substance P, that information is then moving up that blue neuron to the brain. And so that was where the target for the SSRIs and the NRIs is localized here, because that's where those neurotransmitters are released. When we're talking about the NSAIDs, we are working upstream or downstream. We're working before we get to there, right? So we're working out in the periphery when we're talking about these particular drugs. And one of the things that they are inhibiting is this cell's response to that tissue damage. So tissue damage activates a pathway that increases prostaglandins, which are going to bind and activate that neuron. And so what the NSAIDs are going to do, they're going to inhibit that here. So they're really inhibiting it at the periphery, not in that central synapse that we've talked about before. And so the way things work, I have it in image form so you can highlight it, and then I also have it in word form over here. So what happens is that you have whatever cause of pain it is, whether it's mechanical, chemical, or temperature, and that's starting to cause tissue damage. And then that's going to increase this arachidonic acid, which is then going to stimulate the production of cyclooxygenase. And really it stimulates the production of two subtypes. You have COX-1 and you have COX-2, and those are going to do two different things. So activation of COX-2 leads to prostaglandin release, and that leads to inflammation and pain. And then COX-1 actually increases prostaglandins, but in different areas, right? So gut, kidney, and platelet activation. So one of the things that you see, so this COX-1 and COX-2, you can see goes into a little bit more detail here, where you're activating those prostaglandins and then you're getting that pain. Inflammation also happens here too. And what happens for those non-steroidal anti-inflammatory drugs, the most common being aspirin and ibuprofen, so those are actually going to inhibit the activity of COX-1 and COX-2. So they're going to inhibit those enzymes so that you don't get the prostaglandins increase when those are normally active. And so when you're thinking about pain, right, if you have those prostaglandins active, they're going to activate this neuron, you're going to perceive pain. But if you stop the production of those prostaglandins, then you aren't going to be able to feel that. However, many of them don't just inhibit one of COX-1 or COX-2. And that's why if anyone has ever had stomach issues after they have taken ibuprofen, and if you read the label on ibuprofen, they recommend that you take it with food, and that is because NSAIDs like ibuprofen inhibit both COX-1 and COX-2, right? Inhibits COX-2, and then you get the pain relief and reduced inflammation, but you're also going to inhibit this other pathway, which actually is a protective pathway, and then you're going to get these unwanted side effects because they are inhibiting the prostaglandin in the gut and the kidney as well. So if you want to write that down, that cyclooxygenase enzyme increases release of prostaglandins, and those prostaglandins are going to activate those nociceptors, and then you're going to get that perception of pain. But we use NSAIDs to inhibit that COX activity, which decreases the prostaglandin activity and reduces that pain. So if you want to draw a big X here for NSAIDs, that's the simplest way to recognize it. So in the periphery, preventing that signal from getting to the central nervous system. Now, what I mentioned, some NSAIDs like ibuprofen are going to inhibit both COX-1 and COX-2. And if you're inhibiting COX-1, you're also getting those negative side effects that you don't necessarily want. There are some NSAIDs that are selective for COX-2. And so if you're only inhibiting this over here, then this is happening fine and you don't get those unwanted side effects. And if you want to highlight the ones that are only inhibiting COX-2, that tends to be Celebrex, Lumiracoxib, and the Mobic. You wanted to get more specific. But like I said, the most common ones are aspirin and ibuprofen. And I do want to come back to the list that I have. So, most of these you're probably not going to be familiar with, and that's totally fine. They're just different iterations of these specific subtypes. But I do want to say that acetaminophen is technically not a non-steroidal anti-inflammatory drug. So it's actually acting along the same pathway, but what it is, so where Ibuprofen and aspirin are functioning at inhibiting the cyclooxygenase enzymes. The acetaminophen is actually a little bit farther down in the pathway. There's also POX, which acetaminophen is going to inhibit. So often acetaminophen is put in the same categories, but because it does not have the anti-inflammatory properties like ibuprofen and aspirin, it is not an NSAID. And just as a fun fact, the aspirin or acetylsalicylic acid is a substance, well, it's not acetylsalicylic acid, but it's salicylic acid that is in willow bark. So if you have heard of like home remedies, like willow bark tea, you brew that and then you'll get that salicylic acid, which often provides that pain relief. Acetylsalicylic acid was originally created by Bayer and is known as Bayer aspirin because Dr. Bayer was the one who originally isolated it from the willow tree. And I've also included this particular image, thinking about mild to moderate to severe pain. So when are some of these things going to work? So we talked about the opiates, acetaminophen, Percocets. Also, I consider them as opiates, so they are acting on opioid receptors. So I'll kind of put those two together. You can see that, so NSAIDs really only work for mild to moderate pain. They don't often work for centrally acting pain, mainly for peripheral action. But then you can have muscle relaxants and then some other neuropathic pain agents. But when you're talking about severe pain, mainly opiates and those other neuropathic pain agents are going to be able to act there. And then I also like how they color code it nicely, so acetaminophen. And then some of your NSAIDs, ibuprofen, naproxen, ketorolac. And then your opiates or your opiate combinations, cyclobenzapine, baclofen, gabapentin, and pregabalin. We have talked about a few of these. So gabapentin is going to inhibit overall neurotransmitter release, often functioning on voltage-gated calcium channels, so that any signal that's coming in is not going to get transmitted to the receiving cell. So inhibiting neurotransmitter release. So pregabalin and gabapentin having really the same mechanism where they are binding to these voltage-gated calcium channels so that you're not going to get release of those neurotransmitters involved in the pain response. And baclofen we've actually looked at before. One of its mechanisms is to activate GABA B receptors, so again, increasing inhibition. And then I have to say, I don't know why these baclofen and cyclobenzaprine are included in the same thing, because they both prevent muscle spasms, but they have a different mechanism of action. And the cyclobenzaprine has a lot of different things. So if you look it up real quickly, it is an antagonist for histamine, it can be an antagonist for serotonin, and an antagonist for norepinephrine as well, and they've shown that it does other things. One of the things that has a similar structure as the tricyclic antidepressants, so which makes sense of the action on serotonin and norepinephrine as well. And then in the latter parts of the handout, I just wanted to give you more things, because it's like pain. We talked a little bit about some of those pain things, but there is more to it, and just organized in a slightly different way. So if you wanted to look at some of these other compounds that are available for inhibiting other specific types of pain, you can. There are a couple things. So SMP is sympathetically maintained pain. So the sympathetic division of the autonomic nervous system, when that is activated, that can increase, or continually activated, that can increase pain perception. Allodynia is also increased pain to stimuli that doesn't normally cause it, or is not normally interpreted as a painful stimulus. Those are just some extra things. And then I thought this one was cool, so looking at the different common painkillers, and one thing to note is that these dark blue ones here are all opioid analgesics, so there are a lot of those available. And then you have the regular NSAIDs as aspirin and ibuprofen, or the acetaminophen or Tylenol, which we talked about as well. And then just looking at this, we really didn't talk about like the specific cytokines that can be activated to upregulate COX and then possibly lead to chronic pain, but these are other ways of experiencing pain. So if you get an injury, that leads to that acute pain. If that is prolonged, then you can increase some of these things, and then that can possibly lead to chronic pain perception as well.